ठीक
सर लाइव हो गया.
ओके ओके. Hello guys, just give me a thumbs up to let me know that the audiovisual part is okay and you guys are able to connect with me. Okay, perfect enough. So I'm Dr. Mukul Mohindra and I'm your orthopedic instructor here at Medway, and this is a special session that's been organized to have a quick recall of the FMGE exam that has just gone by. The idea behind this recall is that we discuss the questions that came this year so that we learn from our mistakes, and at least in case any other exam you take up in future, which perhaps you will have to, you don't commit the same mistakes, you fare up better and you're able to clinch even a better attempt. So without wasting much of time, I'll just begin. So this was the question: a young adult, he's come to you with fallen outstretched hand, but then it was written that he's landed up with some kind of a fracture at the base of the first metacarpal, and I think you were asked about the correct diagnosis. Now if only I go through this much of information, a young adult who has had a fallen outstretched hand, in this scenario my diagnosis would generally be a fracture of scaphoid, because mostly young people with fallen outstretched hand would be cases of scaphoid injury. But fallen outstretched hand doesn't mean that you are limited to scaphoid. Scaphoid would generally be the commonest bone that would fracture, but other bones also have a tendency to get injured in such kind of a scenario. Now here the examiner had connected another line where he had clearly mentioned to you that this patient has landed up with fracture at the base of the first metacarpal. So actually now we had to think of some fracture at the base of the first metacarpal in this scenario. So a much better answer would here be Bennett's fracture. Actually, if you talk about the base of the first metacarpal, there are two common fracture patterns that could involve this area, the Bennett and the Rolando. The difference is the shape between the two fractures. You find an oblique shaped fracture, that is Bennett. You find a Y shaped fracture, that is Rolando, like you see over here. So the shape makes the difference in the two scenarios, but both of them are fractures at the base of the first metacarpal. So here in this particular case, Bennett fracture would generally be the answer. A car hits you from outside, resulting in the proximal tibia fibula getting fractured. The appropriate diagnosis. So this is just a repeat question from one of the previous FMG exams. The answer here is a bumper fracture. See, a car would hit you from outside. So when something would hit you from outside, the proximal lateral tibial plateau would fracture. So if the proximal lateral tibial plateau fractures, this kind of a fracture pattern where even the fibula can break is what is labeled as the bumper fracture. So clear enough with this guys? So clear with the answers to these two questions. So these questions I suppose were from the area of the fracture. Okay. So Khushi is asking me here in this particular question कि scaphoid क्यों नहीं होगा? Because scaphoid is not a fracture at the base of the first metacarpal. So please be very clear. The first metacarpal means the metacarpal of the thumb. Thumb metacarpal articulates not directly with the scaphoid. Scaphoid is the bone of the proximal carpal row. Then there is a distal carpal row, and then comes the first metacarpal. Getting it? So if you talk of the carpo-metacarpal joint also here, okay. So actually the bone that will be here along with it would be the trapezoid. Scaphoid will be in the proximal carpal row. So base of the first metacarpal is getting fractured. It will be Bennett, not scaphoid. Scaphoid is not even nearby. It is below even the trapezoid. Clear with your query? Khushi? So I hope that clears your doubt as well. Fine. So you guys are clear with these two questions from the area of the fractures. Now another question overlapping the area of the fractures, or you can say most appropriately the area of the Physeal injury. This topic was being asked. So you had been given some kind of an X-ray, as I have heard, and perhaps you could see a Physeal injury to the growth plate, and you could see an epiphyseal chunk with a small chunk of metaphysis, and you were asked what type of Physeal injury is it. So I think you're already very much aware about the Salter-Harris classification, where you have those 5 types. Okay, type 5 is simply a Physeal crushing. So that goes out of the picture. So you were to choose between 4 types. So type 5 was already out. Type 3, as I know, was not in the choices. So you have to pick between 1, 2 or 4 only. Okay, now in type 1, it would simply be a separation of epiphyses and metaphyses. So simple separation would be type 1, but people were saying it was not a kind of a simple separation. Some kind of a chip was also visible. So I rule out type 1 also as the answer, which means either it had to be type 4 or type 2. So that's where people were confused. Was it type 2 or was it type 4? So I would tell you this particular difference also. So when you talk of type 2, the epiphysis whole will be intact and would be connected to a metaphyseal chunk. But in type 4, the epiphysis would have a break apart from this metaphyseal chunk. So you have to just see whether this complete epiphysis is intact or this epiphysis is broken along with this chunk. Epiphysis was broken, it was type 4. Epiphysis was intact, it was type 2. As far as I have got to know, the answer type 2, because people were saying they could see full epiphysis intact with a small chunk of metaphysis. Well, let me tell you otherwise also. If you just ask me which is overall most common type amongst the Physeal injuries, it tends to be type 2. So clear enough with this one, guys? Clear enough? Yes. So I hope you are clear with these 3 questions. You are clear with the topics also, perhaps what was asked. So these were the questions from basically the trauma area, and I'm quite now clear that you're clear with these 3 answers. I'm hopeful you've done them correct because they're very, very simple questions. Now oncology area is another area that gives you at least a couple of questions almost every time in your exam, and I stress a lot upon these bone tumors. The first question that came from the area of the oncology was simply the Codman's triangle, and you were simply asked that Codman's triangle is seen in which scenario. So I'll tell you, Codman's triangle, if I have to put it in just one word, it is nothing else, it is simply a periosteal reaction. So periosteal reaction basically means a new bone formation that happens under the periosteum of the bone from any condition. So actually Codman's triangle is bound to have multiple causes. Now please just understand, Codman's triangle could be from any reason that can lead to periosteal reaction, but osteosarcoma would be the most common reason behind such a thing that is visible on the X-ray. Now what happens in Codman's triangle? So I hope you can see this new bone formation. So this is the whole tumor. This tumor could be eating up the bone also here in maybe the later stages, and this periosteal reaction would take the shape of a triangle like this. That is Codman's triangle. It's classical of osteosarcoma. It is also seen in Ewing sarcoma. So if the question was Codman's triangle is seen in all except, then you have to think accordingly. If it was simply Codman's triangle is seen in, the most appropriate answer in that scenario would be osteosarcoma. Clear with that, guys? Another one, which confused the people a lot was an X-ray of calcaneum showing some kind of a bony outgrowth, as people were talking of. So you have to see what this bony outgrowth was and then click up the answer. People were telling me that most of the choices were pointing towards the area of the bone tumors. So that's where I think osteochondroma would be the best pick in this particular scenario. But just giving you a glimpse of the important lesions around the calcaneum area if you find these bony outgrowths. The Hagelin deformity is seen in this posterior superior area of the calcaneum. So here you have an abnormal bone formation, and this will classically be involving the posterior superior calcaneum. I have marked this area for you. So if you have bone formation in this particular area, somewhere over here like this, that is where you use the word Hagelin deformity. Now at the back of the calcaneum, you have the calcaneal tuberosity. So if you have calcification over here, that is insertional tendinitis of tendo achilles. So here in insertional tendinitis of this tendoachilles, the calcification will be classically seen at the calcaneal tuberosity. Clear with that? Now another very common finding is this calcaneal spur, and I think the spur is very well visible over here. These spurs are simply result of traction. They are traction spurs, and they are classically a feature of this problem that you guys might know as the plantar fasciitis. Inflammation of the plantar fascia in people who jog too much, who walk too much, who walk on uneven surfaces, who use bad footwears. So these are some of the causes of bony outgrowths in the calcaneum. But if you talk of the tumor causing a bony outgrowth, the first thing that should be on your mind should be the osteoporosis. So I hope you guys are all comfortable with the audiovisual part. You're able to see and hear what I'm saying. You're able to comprehend me very well, and these X-rays and slides are like clear to you. So is everything fine, guys? People are watching the session live. So perhaps the whole idea behind this discussion is that, of course, I give you a kind of rough calculation about your attempt, but more than that, this is not an end exam. There are more exams that will be coming your way, because there is so much more for you to achieve, guys. And perhaps with this you just sharpen your skills a little more, you increment your knowledge a little more, so that next time anything related to this topic comes up, you are able to take it up in a very convincing and an effective way. Okay, now there was a question on tuberculosis of the hip also. So this particular question was focusing on TB of the hip joint. Maybe a young female was mentioned who was having some involvement of hip, and she had come to you with this flexion, adduction, internal rotation deformity, and it was written that there is appreciable amount of shortening, I suppose. So this is the input that I have received. The question had these particular words. So in case you guys feel anywhere there is something you can add upon, please just feel free to comment and let me know. Okay. Yes. So I'll just brief to you about the stages of tuberculosis. Although the complete detail I have posted it for you, but I'll just give you a brief outline about it. See, tuberculosis of the hip, when it would start in the acetabular roof. This will be the commonest starting point, or it would start in the femur neck. Now in the femur neck there is a very special area that is called Babcock triangle. So this Babcock triangle is notorious where TB of the hip starts in the bone. Now once this TB of the hip starts, first there will be synovitis. The synovium will be inflamed, and then the cartilage would start degenerating, going through the phases of early arthritis and then late arthritis, and eventually there's a pathological dislocation that happens. So this is already giving you the scenario in which TB progresses and destroys the hip joint in a normal person. Now different deformities come up in different stages. So when it is synovitis, you need space because there's inflammation, there's collection. So maximum space is there in this position: flexion, abduction, external rotation. And then because of soft tissue lengthening, in this stage there could be apparent lengthening. Apparent means the lengthening is not real, the bone is not longer than the other, it is simply because of stretching and adjustment of the tissues. Now as synovitis progresses to arthritis, scenario changes. So in early arthritis the deformity starts changing to father deformity, and here you start getting apparent shortenings because of contractures of the tissue. So tissues would contract up, pull bones closer to each other, so apparent shortening would come up. So the true length of the bone is same, but contractures have led to shortening, an appearance of shortening. So here shortening is mild. Now as the things would go further, the father deformity would be persisting because of muscle spasms, but here bone will also start getting destroyed, and both true and apparent shortening would come up. Now please, if you look at this question, father deformity is mentioned, but the examiner has mentioned the word there is appreciable shortening, significant amount of shortening. So if the shortening mentioned was significant, my approach will be more towards late arthritis. If so, that's one of the common scenarios. Oops, I think there's a small technical glitch because of some reason. Just need to reconnect it. I'll just do it in a while. Please allow me 2 minutes. I think this may be a network disruption on my side. Okay, alright, no issues. I think I can take up an easier way. Open it up on my laptop and we can just safely continue from here. Yeah. Alright. So I suppose that's also okay with you guys. Okay, fair enough. Okay. So the question was that there's a motorcyclist who's landed up with a road traffic accident and he develops hypothenar atrophy, and then it was clearly written that he cannot flex the MCP joints, so these will be the metacarpopharyngeal joints, okay, and he cannot even extend the interpharyngeal joints. So interpharyngeal joints are in flexion, the MCP joint is in extension, because flexion at MCP is defective, extension at IP is defective. So reverse of this is flexion at MCP, extension at IP. So basically examiner indirectly was trying to tell you that there is claw hand. So with that mention of claw hand, I think you're very much clear with the part that this was a case of ulnar nerve palsy. So here the answer would be ulnar nerve. Okay, I think this was a quite simple kind of a question. So here ulnar nerve would have been the best answer. Clear with that? So clawing was telling you the whole story, and perhaps this hypothenar atrophy was also telling you the whole story. So I think with this it was quite okay, and you could see that the examiner had mentioned about clawing, and perhaps the examiner had spoken about this clawing and this hypothenar atrophy. So everything telling you this is a case of ulnar nerve. Radial nerve would have given you wrist drop, and median nerve would not have allowed flexion of the fingers, those kind of scenarios. So without any issue, I think the answer, perhaps that was ulnar nerve. Now rickets is due to deficiency of, I think this was a kind of a question to make sure that no one goes home without a mark. So I think everyone knows rickets would be vitamin D deficiency perhaps, and we are quite much clear with this particular one. So last easy one to discuss. So that's all the recall questions I could manage. Perhaps I think these were the questions that have come up from the area of orthopedics. My take home message after looking at these questions, that the questions were simple, very basic. So sticking to basics remains one of the important formula for people waiting for this exam. Most of the times questions were having clubbing of different areas, like lot of orthopedic questions were overlapping with the images. You could see that x-rays were posted for both the tumors and of course that Physeal injury case. So you had to be good with radiology knowledge as well as orthopedic knowledge, and then identification of those sites, calcaneum, which area is having the bone mass. So you had to be clear with the anatomy. So it was the questions not limited to orthopedics, but somewhere testing your radiology anatomy knowledge as well. The questions were quite clinical. The examiner could have simply mentioned claw hand, but he talked of some flexion at the MCP, extension at the IP. So he was checking your understanding. So perhaps sticking to the mnemonics and mugging up and cramming is no way the way forward. So the examiner wants you to understand the things, make concepts, and go through the questions in a nice way. Don't overlook a question that's a simple one. You could very well see, fall on an outset hand question with that scaphoid and Bennett confusion. So he wanted you to make sure that you go through everything. That TB question was made in such a good clinical way that until unless you don't go through the question, you have the entire understanding of the topic, no way could you have hit the answer. So that's what my message to you is: learn from your mistakes, so that in future you don't commit the same mistakes. Okay, I have discussed the topics that came to me. Anything you miss, you can connect to me later also and let me know, and maybe I'll put up the answers later also. So I hope you had a exam that was good. and you are expecting a good rank, my best wishes with you. I'm sure you guys would be through, and we'll meet up again for the NEET preparation. So all the best. See you again, guys. Bye bye.